let's start. So welcome to all to this talk. Great that there are so many people online. Unfortunately, we couldn't get Jeremy Grimshaw directly by us, given the current travel issues. But it's a great pleasure to have Jeremy Grimshaw for a talk today. So we worked quite a lot in the last years with him about several EU grants we submitted, and it's an international expert in the field of implementation research. So he was also trained before as a family physician. So from the BM point of view, it's also good. As we see, there's good possibility for career, even when starting as a family doctor. But then he made also PhD in health science, then he moved to Canada, and currently is a senior scientist, clinical epidemiologist at University of Ottawa, and is a full professor at the Department of Medicine. He has over 650 peer-reviewed publications. He has constantly been ranked as one of the highly cited researcher by Thomson Reuters since 2015. So really a well-known international speaker, and today we'll speak about one of his favorite topic, which is about implementation, and the title is about evidence is not self-implementing, building the science for implementation. And as usual at this talk, so the question will be at the end of the talk, but if you have questions during the talk, you can put them in the chat, and we will go through most of it at the end. So Jeremy, so great to have us with you, and the floor is yours for your presentation, and looking forward hopefully for a lot of questions on your presentation. So thanks again to join us here in Bern, at least virtually.
Thanks a lot, Nicholas, and I'm delighted to be here. I wish I was there in person. I see lots of names I recognise in the room, so it would have been lovely to catch up with many more people in person. Hold on a second. So originally, my plan was to send you greetings from Ottawa, but I had a family death last week and had to come across to the UK for the funeral. So this is where I am at the moment. It's I'm on the south side of the of the Tay River, just south of Dundee, and this is looking across at low tide. So greetings from Scotland to you all there. What I want to do today is give you a very high-level overview of how I see implementation science, often using examples from my own work, and then thinking about some of the sort of, I think, challenges and opportunities for the field. I noticed after I had been invited to this to give this lecture, I think about a month ago, there was a session in Switzerland somewhere, and the Twitter entry was, "Is Switzerland ready for implementation research?" So I hope at the end of this you'll be able to tell me whether you are or not. So this is the reason that I have got out of bed for the last 30 odd years. Probably the most consistent finding of health services research globally is the gap between what evidence says we should be providing to our patients and what healthcare professionals and healthcare systems actually manage to provide. So between 30 to 40% of patients don't get treatments of proven effectiveness, and about 20 to 25% of patients get care that is not needed or is potentially harmful. And the fact that there's no healthcare system in the world that has got this right, I think, highlights that this is a very wicked problem. It suggests that implementation of research findings is a fundamental challenge for all healthcare systems to optimize care, outcomes, and costs, and something that we really have to pay great attention to if we want to provide the best care for our patients. So implementation science, this is where implementation science comes in. And the issue is that implementation is a human enterprise. We can study it to both understand and try and improve implementation approaches. So implementation science is a scientific study of the determinants, processes, and outcomes of implementation. And the goal is to develop a generalizable empirical and theoretical basis to optimize implementation activities, but also to develop practical approaches and resources to health systems. I see implementation science as very much an applied science. What we're trying to do is generate a knowledge base that healthcare organizations or healthcare systems can use to try and improve the quality of care that the patients receive. It's inherently interdisciplinary. There's no one discipline that has the monopoly on the information that, or the perspectives we need to make sense of this. So we need a wide range of disciplines to be involved, including people from clinical backgrounds, health services research, social sciences, organizational sciences, design and engineering, informatics, methodologists. And I'm going to sort of highlight some of the work I've done. I tend to focus upon systematic reviews and trials and quasi-experiments, but I want to start out by saying we need a broad range of forms of inquiry. There's not one way to get or to solve this puzzle. We need many different groups coming at this with their perspectives, their methods, trying to make sense of this, and then for us to sort of very critically look at what each discipline and method can contribute and use that to develop basically the science of implementation. So this is a busy slide, but this kind of highlights my mental scheme about what's included in implementation science. And what I'm going to do during the talk is particularly talk about the bolded areas, but knowledge synthesis that can help us both to understand what care we should be providing and also what we know about the effectiveness of different implementation approaches. Research into the evolution and critical discourse around evidence. How does evidence evolve and when is it ready for thinking about implementation? Johnny Inardis has done a landmark series of studies in that area. Research into knowledge retrieval, evaluation, and knowledge management infrastructure. Compared to where we were 30 years ago, we are so far ahead in terms of these areas, but that's due to the work of people like Brian Haynes and Anne McKibben and many other information scientists around the world who really have helped address that. Identifying implementation failures, developing methods to assess barriers and facilitators to implementation, methods for optimizing implementation programs, evaluating the effectiveness and efficiency of programs, and then thinking about sustainability and scalability. And all the time as we're doing this, developing theory, methods, and tools. So I want to start off by talking a bit about knowledge synthesis. And again, I started my research career in 1989. And the world was a very different place at that point in time. It was actually very hard to find good evidence-based advice about the care that you were that we provided. We really were looking at textbooks which were out of date and an apprentice model. The world has changed dramatically in 30 odd years and to the better. So if we're thinking about systematic reviews as a unit of knowledge that we should use when we are thinking about whether to implement or not a piece of evidence, then the global Cochrane collaboration has made a major contribution to that and now has 8,000 to 10,000 completed reviews, which are high quality and relatively up-to-date and hopefully increasingly up-to-date in the Cochrane Library. I'm delighted to see my old friend and colleague Bernard Benand on the call, who for many years really led the charge for Cochrane in Switzerland and did an amazing job. So we have a great resource for clinicians and healthcare systems and patients who now want to know what care we should be providing. We also have, and I'm not sure about the situation in Switzerland, but in many countries there are now guideline agencies that are using robust methods to develop guidelines which go beyond syntheses. They add more interpretation and try and create a more comprehensive roadmap about the care we should be providing. Clearly, both in terms of systematic reviews and guidelines, not all of them are equal. And when we're thinking about using them, we should be very critically using things like tools like AMSTAR and AGREE to basically assess whether these guidelines or systematic reviews are trustworthy for us to think about changing behavior and practice. We can also look at knowledge syntheses to look at the effectiveness of different implementation approaches. So for many years, I was the coordinating editor for the Cochrane Effective Practice of Care, Effective Practice and Organisation of Care group. And that was a group in Cochrane that tried to summarise evidence on how to improve healthcare delivery and how to improve healthcare systems. And they now have well over 100 reviews that cover many of the key sort of strategies we should be thinking about. As one example, this was a review that was undertaken by my colleague Noah Ivers on audit and feedback. It was published in 2012. There were 140 randomized trials of audit and feedback at that time, and the median absolute improvement in care was about a 4% improvement with an interquartile range of 0.5 to 16%. This is very typical of the pattern we see in systematic reviews. We commonly see that in general things seem to work, but there's a lot of variability in terms of the observed effects, suggesting we don't necessarily understand under what circumstances should we apply an intervention and how do we optimize it. And I think a lot of the science has to be moving into, how do we actually sort of get the maximum effects out of interventions? So instead of getting a 4% improvement from audit and feedback, how do we get a 6, 7, 8% improvement as we move forward? Just as an update, Noah Ivers is currently updating this review, and I think now there are around 340 trials, and that review will likely be released by Cochrane sometime in 2022. When we look at implementation strategies, one of the key issues is trying to make sure that we're choosing the right strategy for the right problem and for the context. So we need to understand what are the barriers and facilitators to implementation to help inform which interventions we should think about considering and how we might want to best optimize those. And the challenge here is that there are many barriers to implementation. They could be at the structural level, the way we reimburse healthcare professionals or healthcare organizations, or scopes of practice of healthcare professionals within specific jurisdictions. They may be at the organizational level if we don't have the right mixture of healthcare professionals or lack of facilities or equipment. They may be at the peer group level. What we consistently observe is that when human beings work together, whether it's in health or other settings, they often will develop local norms, local standards, local ways of doing things. And if basically those local ways of doing things are different to the evidence-based approach, it's often a real challenge to get people to change their behavior from these local ingrained practices and routines to evidence-based practice. The barriers can be individual healthcare professional level relating to knowledge, attitudinal skills, and they can also relate to the limits of human information processing. Human beings have finite brains. We don't have supercomputers. And so basically that drives how we try and get through the day. And we have a number of ways of trying to do that. One is that we have lots of habits and routines. And when we're clinicians, again, we very quickly across our careers start to produce habits and routines which allow us to move through the day without having to think every problem through from scratch. And also when the human brain is asked to do multiple tasks at the same time, we'll often forget to do some things. So there'll often be acts of omission, not because we don't know what to do, it's just that actually we're a bit overwhelmed in an acute clinical environment. So all of these barriers exist, and depending on the barrier, we might need different solutions. One thing I would like to say here is that historically, we've often assumed that professional knowledge is the main barrier, and that's led to a great focus on education as our main strategy to address this. We are finding consistently in study after study across a wide range of settings that often healthcare professional knowledge is good enough. It may not be perfect, but it's probably good enough, and it's often barriers at other levels which really get in the way. So from my perspective, really from very early on in my career, we took a behavioral perspective. If we think about implementation, someone needs to change their behavior, whether it's the citizens or patients, health professionals, managers, or policymakers. So implementation inherently has someone changing their behavior, whether it's starting a new behavior, stopping an old behavior, or basically switching between behaviors. And so if we want to improve care, we need to change behavior. And so to change behavior, it helps to understand determinants of current behavior and how behavior changes. So we have done a lot of work using this framework that we think is particularly helpful. It's called the Theoretical Domains Framework and is originally developed by Susan Minke. And basically, Susan, with colleagues, tried to identify how many unique ideas health and social psychology says drives our behaviors. So instead of dealing with multiple conflicting or incomplete theories, this is basically a summary of what health and social psychology says drive our behaviors. And here are the 14 things identified in the Theoretical Domains Framework. You may not necessarily recognize all of the language here, but it shouldn't be anything that's that surprising to you. If we don't have the skills to do something, we're unlikely to do it or to do it well. If we don't believe that doing something will lead to a positive consequence, we're unlikely to do it. If we, in a busy clinical environment, forget things because our brains are stretched, then we won't do it. If there are things that are environmental contexts which make it harder, even by a few seconds, to do something that in a busy clinical setting will probably not do it. And also, if we have people who are important to us, but they do not support an evidence-based practice, they will likely influence what our behavior and practice is. So the nice thing about this is that this is a comprehensive assessment of what health and social psychology says drives our behaviors. It doesn't just focus at the individual level, because when we actually use this, we find that often people are identifying environmental context and resources or social influences or things in the wider environment context that influence their behavior. One of the things about the TDF is that you can use either qualitative or quantitative methods if you want to evaluate this. There is an interview which can be conducted in most circumstances within about 30 to 40 minutes, where you can quickly identify which of the 14 domains are most important and what are the key beliefs that may need to be challenged within that. And here is just an example of a study that we did looking at basically why intermittent auscultation during the first stage of labour was often underdone. So we're starting to develop tools around how to assess buyers and facilitators. There's other really outstanding work out there. I particularly highlight the work of the Consolidated Framework for Implementation that was developed by Laura Damschreiber and colleagues, and also Carl May's normal personalization theory are all very helpful tools here. So we're all trying these different areas, and at some point in time, we need to come together and say, well, how do we work out what will be the optimal package for groups trying to make sense of this? If we then think about development of methods for optimizing implementation programs, a number of you will remember my colleague Martin Eccles, who was my associate in crime for many, many years. And he said that his experience of watching people in healthcare systems trying to develop interventions is that they often use what he called the ISGLIAT principle. And that stands for, it seemed like a good idea at the time. Often senior tables of very well-meaning people get together and suddenly an idea comes to the fore and people run with it. And there's no discussion about, well, what do we think the problem is? Why do we think this intervention might be a good solution for it? What might go wrong? What would you need to do to make that intervention work? And what we found is that sometimes when people use those sort of more experiential, tacit approaches, they develop interventions that work great, but often they don't, because they've not fully articulated what the problem is, and they haven't fully thought through why their intervention may or may not be appropriate for that problem. So we again have been working with this model, which was developed by Simon French, and it's a relatively straightforward model, but it breaks down thinking through implementation strategies into four boxes. Who needs to do what differently? So that's understanding what the barriers are and facilitators are for the people that need to change their behaviour. Using a theoretical framework, and then identifying what intervention components can overcome the modifiable barriers and enhance enablers, and then thinking about implementing the strategy and measuring behavior change. So this isn't, when I present this, it's like many models, it's a very simple model. Our experience time after time is that too often in healthcare systems, because healthcare professionals and managers are very solution oriented, people jump to step 3 without actually thinking through steps 1 and 2. And we would argue that's why often those experientially derived interventions may not work as well as they could. So this is a very useful model for just thinking through how to design your intervention. We can also draw upon existing theory and expert advice. So this is work that's done by my colleague Jamie Briho, whose office is next door to mine when we're back in the work building in Ottawa. But he wanted to basically try and identify what do experts and what does theory think might optimize audit and feedback. And he interviewed 30 experts from around the world who came at audit and feedback from different perspectives, some from cognitive psychology, some from education, some from organizational sciences, and basically asked them, gave them examples of audit and feedback in healthcare and asked them how it could be optimized. And he came up with 15 suggestions, which felt like they're low-hanging fruit. A lot of these have got good empirical basis or a very, very strong theoretical perspective. So that if you were thinking of trying to design an audit and feedback intervention, then this would be one of the ways in which you could try and increase the likelihood that your audit and feedback is going to be maximally effective when you roll it out to your colleagues. The final thing I want to mention is the opportunities to do A/B testing. So ideally what we'd like to actually sort of maximally improve our knowledge base is, when we first introduce a strategy or intervention, we'd like to evaluate that using either a cluster trial or a quasi-experimental intervention. Sometimes that's not possible, but even when we've introduced interventions, it is possible then to actually test different variants of that intervention as you are delivering the intervention to see if you can improve care. And this is called A/B testing. And this is what Google does probably thousands of times a day. Whenever you go onto Google, you're going to be subject to probably 4 to 5 different experiments. And they're trying to just sort of basically say, if we position this text 3 centimeters to the left, does that increase the number of click-throughs? We can use those approaches when we're thinking about how to optimize interventions. So if we think during the COVID era, and we think about interventions like test and trace, there may be a whole range of ways in which you can improve that in terms of how we approach people. What are the scripts that people use as they're trying to elicit advice about the contacts of individuals? What are the ways of really encouraging people to say isolate around that? And it would be possible to, on the basis of your base model for test and trace, to then think about, let's develop an add-on and see if we add on, and then test the base model plus the base model plus the add-on and see if the add-on improves the effectiveness of our intervention. So we can continually improve what we're doing as we're moving forward. And we had a paper describing this in BMJ Quality and Safety a couple of years ago. So I next want to move on to evaluation of implementation programs. And I'm a very firm believer that in general, largely pragmatic cluster randomized trials are the best way to evaluate implementation strategies. And the reason for this is because we have a very incomplete understanding of confounders. So even if we were able to do high quality observational work, I frankly would not know what to correct for. And there's a danger that we would be overcorrecting or undercorrecting and being misled by the results. the effect sizes we're seeing are relatively modest. So I mentioned, most of the interventions seem to have between about a 4 to 8% improvement. And so if we use weak evaluative designs, there's a real chance that we may mislead ourselves due to, basically unrecognized bias as we move forward. And also there are significant opportunity costs if we get it wrong. So I do believe that the arguments that we would use about why we want to have trials of, say, clinical interventions in human subjects are exactly the same about why we want to have trials for implementation strategies. And I want to give you an example here, which I have to confess is probably one of the most compelling examples of my career. The person in the photo is Professor Sandy Middleton. She's a professor of stroke nursing at the Australian Catholic University in Sydney. And this was her first trial after she finished her PhD. There's basically good epidemiological data and also good basic science data that suggested that people who spiked a temperature in the first 72 hours after a stroke had worse outcomes, or people whose blood glucose got out of control had worse outcomes, and that people who didn't have an early swallowing test had worse outcomes. So Sandy wanted to know if we try to improve the sort of management of these three areas by nurses in the first 72 hours of admission of a stroke unit, did that lead to better outcomes? So this was already building upon the benefit that patients get by being in a stroke unit. So this was saying, in addition to the sort of the huge benefit you get by being in an organized unit, if we then try and optimize aspects of nursing care, do you get any further improvements? I thought it was a big ask. I didn't really think it would work. So we randomized, I think, 19 stroke units in New South Wales. And what we found is that with the primary outcome, the trial initially was the proportion of patients who were dead or dependent, i.e. couldn't get home, with a modified Rankin score of greater or equal to 2 at 90 days. And we demonstrated that there was a 15.7% reduction in death or severe dependence in patients who had managed in the stroke units who had the implementation strategy to optimize care compared to those in the control group. Now, when I first introduced this, I said we had good observational data. We didn't have good trial data. So what we were interested in doing is also doing what we called a hybrid trial. So looking to see if the changes in outcome were also linked to changes in process of care, which would give us confidence that both the mechanism of action of the intervention was correct, the clinical intervention, as well as the implementation approach. Sorry, I'm jumping ahead. I'll jump ahead. And this is just to show you that although we didn't get to perfect levels of care, we did across these three areas of care show improvements in the intervention arm compared to the control arm for all the patients. This graph is even more striking graph. We followed up patients using registry data over 5 to 6 years after the trial had completed. And what you can see is that the intervention and control arms, the mortality curve differs. And so by five years out, there's about a 4 or 5% absolute improvement in mortality for patients managed in the intervention units compared to the control unit. So here we have an example where our intervention led to the changes in process of care, and it led to quite markedly improvements in outcomes of care. This was picked up by the New South Wales Agency for Clinical Innovation for scaling up and implementation across all the stroke units in New South Wales. And what you have here is just sort of basically is a simple pre-post, because we had the trial data, so it's a rollout. But what you're finding here is you get even larger effects when we rolled out this intervention. Because I think for the first time, this was very powerful evidence saying to nurses, if you change what you do, you can directly impact on patient outcomes. And this was basically, it got the New South Wales Premier's Public Sector Award. And my colleague in the red and the four on top is Simeon Dale, who is the wonderful trial manager who managed this whole process and is just a force of nature, who was just great. There's an independent economic evaluation that suggested that if the protocols were implemented for 65% of eligible Australian patient populations for 1 year, the total economic benefit savings would be about $281 million. So that was within Australia quite a story. We tested an implementation strategy. We could show improvements in the process of care and outcome of care. It was likely cost savings. It was scaled up across the New South Wales state. And now what's happening is, working with the European Stroke Organization, we are basically sort of scaling this up to about 300 hospitals in 12 countries across Europe. So that's just an example of where we are. Nicholas, I need to just. My wife is locked out, and I need to go and let her into the house. So I'm going to go downstairs, and I'll be back in about 45 seconds. I do apologise, but I don't want to leave my wife outside.
Sure, Jeremy. Okay, so we wait 2-3 minutes, and then it should be back. That's how Amoya, the duration. Usually it's 45 or 1 hour. I was not totally sure about the total duration of the talk. Is usually 45 minutes.
Yes, so we plan about 40 to 45 minutes for the presentation, and then 15 to 20 minutes for a question part at the end.
For the question. Okay, thanks for the clarification.
Sorry, I'm back.
Okay. No problem.
So the final sort of point I wanted to draw out of this is that as we're building implementation science, or as we're doing it, we should be thinking about how we develop both the theory, the methods and tools, so that we really should be trying to think about, how does this advance our knowledge? How does this advance our understanding of methods to basically elicit that knowledge better? And to what extent, when we, can we take the models we're developing outside of the research setting in a way that they will be acceptable and helpful to the healthcare system? Okay. So I want to finish off just thinking about some challenges at the moment. So one of the issues is that the language in this field is terrible. We use different language to mean the same thing, and we use the same language to mean different things. And we also have issues when we have different disciplines try to come together. So sociologists and psychologists in the same room often find that they really can't actually communicate because the language is different. So we need to build a shared understanding and language for core concepts about translation. And I'd argue that failure to do that so is limiting scientific progress. This is an area where I think there's been a lot of work in the last 10 years, particularly by colleagues in the US, people like Cara Lewis, Enola Proctor, Byron Wallace. So there's a lot of information. We're getting better at this, but it still is a major issue. And one of the things I would plead is that if people are trying to do implementation research, don't start creating new language or new tools just without being aware of what's already there and making sure that what you're doing is congruent. 20 years ago, I would say there's not enough theory in implementation science. People were just basically plucking things out of the air and not really thinking through what would be helpful. I worry, one of my nagging doubts is that we're getting to the stage where we may have too many theories, but not enough theory. Everyone is developing their own theories, and they're often poorly conceptualized, rarely operationalized, and even more rarely tested. And it doesn't advance science if we develop a theory that is never actually tested in a robust way. Trish Greenhoff came across, and it isn't hers, but one of her slides is that theories are like toothbrushes. No one wants to use someone else's, but actually what we need to do is be prepared to actually take existing theory, which is often built upon quite considerable bodies of evidence, and try and test them to destruction and learn from them as we move forward. I think there's a failure to build informative science. There are many studies out there that provide flawed or limited information. Again, it's getting better, but if you went back probably 15 to 20 years ago, many cluster trials had unit of analysis errors. They weren't well set up. Now I think we've had a much better, with the professionalization of trial units across the world, we're in a situation where often the technical issues don't, or technical flaws don't come in, but often studies aren't designed in a way that maximally help us learn from them. We also have a failure to build cumulative science. So it'll be interesting to see, but when Noah Ivers did his review of his Cochrane review of 140 trials in 2012, we also did a cumulative analysis. And basically the cumulative analysis suggested that we had, in terms of understanding the likely effect size in the interquartile range, we had probably maxed out the information by 30 trials. Yeah, there are another 110 trials done after that. So there's an awful lot of people just repeating studies have already been done in a rather naive way, rather than sort of saying, okay, if we want to use an audience feedback intervention, what do we know about what will maximally work, and how can we do a trial which will be particularly useful to advance our knowledge base here? The next is a question for Matthias Egger, if he's still on the call. One of the issues is what proportion of global research budget should be spent on implementation research. If we want research to make a difference, then we need to adequately support this. When I was in the UK, I chaired the NHS R&D program on methods to evaluate implementation research findings, and they basically put 2 rounds in, £7 million, and at the end is we're like, well, we've done that and we'll move on. This is an ongoing problem. It's not going to be solved by small amounts of research funding. It actually requires quite substantive funding and building large enterprises to make a difference here. So I think we do need to engage with funders about what should be done for this. Even if you're in the stage where 5% of the global research budget was on implementation research, that would help us make a huge difference moving forward. And then there's an ongoing issue about implementing implementation science. I worry that implementation scientists tend to talk to each other and not to people in healthcare systems and healthcare organizations whose job it is to try and do implementation. And we need to find ways of bridging that and really helping them to advance and move forward. As one example of that, we're currently working with WHO, and we're producing an implementation toolkit for their interpartum care guidance, which we're currently testing in Tanzania and Argentina. But we need to do a lot more of these these linkages with this research side and the service side as we're developing tools to make sure that we're not just creating academically nice and pristine products that aren't helpful. In terms of personal advice to people wanting to get into implementation research, I would say it's the science stupid, just to paraphrase, it's the economy stupid. Too often what I see is that people are unambitious and answer questions that aren't that interesting or have already been answered. So I really do think if you're a researcher who's interested in this area, be ambitious. What we often do, you see cluster trials where people say, I can get 12 clusters and therefore my sample size will be divided by 12 clusters, so you have an underpowered trial. If you need 90 clusters, go out and find a way of doing it. Be rigorous. Be very self-critical about what you do. It is so easy to make assumptions, implicit assumptions when you're doing research in this area that basically undermine kind of the credibility of what you're doing. Be thoughtful, cumulative, be collaborative, be engaged, and be committed. A useful a useful sort of idea that was once that Martin Eccles came across once was that someone told him, or he heard at a meeting, any piece of research should advance substantive knowledge, conceptual knowledge, and methodological knowledge. So whenever I'm planning a piece of research, I want to know, well, how can this contribute to, basically our knowledge about, say, how to improve stroke care or nursing care in stroke units? How can it contribute to conceptual knowledge about how to basically improve care in team-based settings, in secondary care settings? And how can it improve methodological knowledge? How could we, think through more carefully or test tools to develop barriers as we're moving forward with this? So we really need to make sure that we are doing the best science we can. And it's too easy to do kind of, not very interesting and not very exciting and not very advancing science. At a higher level, what do we need to do? I think we need to collaborate and collaborate and collaborate. No, very few individual groups have the necessary skill set to cover off all the disciplines that is needed. And also, often if we're working within a single centre, we won't have the number of units if we want to do cluster trials. So we need to build big collaborative ventures. We've been articulating the need for implementation research laboratories, which are special versions of the learning healthcare system, but where you're basically embedding implementation research into service innovation, both at the initial introduction and then using A/B testing as you move forward. We need to think about building capacity equitably. The evidence coming out of low middle income countries is that often implementation efforts get larger effects, larger improvements, probably because they're starting from a lower baseline than we're seeing in higher income countries. So think about what we could do for global health if we had a really big implementation research push globally. And then think about building career paths. In CADA, we've created a lot of implementation and knowledge translation scientists, but we don't have many faculty positions that these people can go into. And so we're training people, but we don't have the career paths for them. We need to do that as well. I think in any individual centre, we need to think about building a critical mass of necessary expertise. These are not all, but most of my colleagues from the Centre of Implementation Research in Ottawa. And I think we're unusual because we're a group of 10 plus 3 scientists, 3 visiting scientists, and the breadth of our skill set. We've got people coming from an implementation science background, cognitive psychology, health psychology, sociology, medical education, design and human factors, shared decision making, journalology, health economics, statistics and study design, and clinical. And that richness of having people who spend 80% of their time thinking about implementation from slightly different perspectives, slightly different methods, means that we are hugely blessed in terms of what we can draw upon. We also sit in the clinical epidemiology program, where we have access to probably 50 clinical scientists who come and knock on your door with really, really interesting, sexy implementation problems. And that critical mass with the clinical content experts and the clinical drivers, I think really is essential if we want to build this forward. So I think I'm coming to the end. So hopefully you've got a little bit about the passion that I have for this area and why I've kind of committed to it for about 30 years. I do think that implementation research is about saving lives, improving health outcomes and the quality of health services. Anyone who's a researcher and is doing research because they hope that their research will, at the end of the day, improve health outcomes or healthcare system performance, you need to be interested in implementation science, even if you're not going to do it, to be aware of that and thinking through, how your research might flow, or how you might create links to groups that can then think about the implementation science perspective. It's a relatively new field of health services research. I started my PhD in 1989. The earliest large-scale studies I identified were done in 1976. So it's a relatively new field of health services. Only in the last, I'd say, 15 years, it's dramatically taken off. So there's a huge amount of work to be done to make sense of this area. We have a substantial evidence base on the effects of different implementation interventions. And when I started my career, both the BMJ and Lancet had published editorials saying the only way you can get physicians to change their behavior is to wait for them to retire or die. And that is completely wrong. The good news is it is possible to change stakeholders' decisions and behaviors. Healthcare professionals are highly motivated to provide the best care they can for their patients. And so if you can help them do that, then they will change their behavior very straightforwardly. But I think the current evidence base provides little practical guidance for healthcare systems about which interventions to use and how to optimize them. And although we have made substantial progress, there's a huge research agenda that still remains there. I do hope that colleagues in Switzerland will also grab this opportunity and do things to both improve care in Switzerland, but also to improve our knowledge base globally so that other countries and jurisdictions and healthcare systems can learn from the Swiss example. So thank you very much, and I'll be very happy to take any questions.
Thanks very much, Jeremy, for the great talk and inspiring ideas and all the gaps that still remain to be done. Now the floor is open to question. I think I have to look at the Zoom if there is any question in the room. I cannot see everyone at the same time, so with a large number of people, so if someone has a question, he can also directly speak because I'm not sure I will see everyone. I see Matthias, you have a question?
Yeah, hi Jeremy, fantastic to see you, and thanks very much for this really tour de force on implementation science. I think from a Swiss perspective, one aspect that perhaps you haven't covered in depth is really that implementation science in the health domain is very much dependent on a health system which allows implementation science. And of course, the Canadian health system is a centralized health system, the UK system, etc., whereas the Swiss system is highly fragmented. It is basically, we have, some people say we have 26 health systems because we have 26 cantons. And I think the COVID crisis has brought this to the fore to some extent. I think in Switzerland, we are ambitious, we are rigorous, we are thoughtful, and we're cumulative, if you like. We also are collaborative, but and so forth. Just going back to your slide, we're very committed, but we lack a healthcare system that really lends itself to do good health services research. And I myself, in my career, I've been trying to do cluster trials in Switzerland, and it's very, very difficult. And the data are not there. The data are cantonal. It's very difficult to access them. Then your question on the funding front, is sort of related to that. If you can't do good health services research, the national funder should not fund it. Now, if you want 5% of the budget of the Swiss National Science Foundation, we're talking about 60 million. I did a little calculation. And, I don't think the situation as it is now could absorb 60 million per year for implementation science in health. And of course, you can, this is the budget for all research. But we did have a national research program which was called Smarter Healthcare. And I don't know whether Marcel is on the call because he is in the steering committee, and it will be very interesting to see what comes out of that national research program, which had a budget of, I think, around 20 million. And I think, perhaps Nicola, you can comment. And I think one of the conclusions, sadly, was that there are major barriers to doing good health services research, barriers to data, for example. So I'll stop here. I hope I've addressed some of your concerns. And again, nice to see you.
It's great to see you, Matthias. So I think there's a number of responses. One is, where there are problems, researchers have to find a way through them. I think this is something where it's not just the research responsibility, it should also be the healthcare system responsibility. This is one of those areas where the healthcare system should more directly benefit from the research in a very tangible way than not. So you could argue that what we need to do is start thinking about, basically healthcare system research collaborations, and maybe you can't go across 26 cantons. Maybe you can go around 4 or 5 as a starting place to do this. Let's start where we are. I remember I gave a presentation to basic cardiovascular scientists, and they were sort of saying, well, it's very hard to do studies with a large number of animals because it's very expensive. And researchers fundamentally have to find ways through brick walls. That's how knowledge advances. So I would be at the research foundation, the funder, be talking to the government and the local governments about other ways of trying to build something that would allow us to do this a bit better. The fact we have 10 provinces and 3 territories, we have 13 healthcare systems, so half the number of cantons. It also allows you to do some compare and contrast stuff. It allows you to start to think about this. One of the issues about when you tend to do implementation research in a single healthcare system, the healthcare system factors are fixed. And so it's very hard to understand. All you can see those healthcare system issues as being context and constraint. And you can't see the extent to which they are effect modifiers. If you can start to do things across multiple healthcare systems, it allows a much more richer discussion about, well, to what extent are those contextual constraints effect modifiers or not. And Nicholas has, with colleagues, has run a number of, and we have an application in to run implementation trials across different European countries. And one of the things I'm excited about that is it actually allows us to think about, at the country level, the context. I'm not sure whether we have variability in the Swiss cantons. So doing this research is always going to be hard. But if you don't start, you're not going to answer it. And my guess is that across the 26 cantons, and Switzerland is a gloriously individual country, as far as I can tell, on many, many different parameters. So if you don't actually start here now, then, you're not going to advance. So I just would encourage you to do that and, think about training, think about collaboration, think about things that actually encourage people in different cantons to work together as part of the infrastructure, what you require for your funding. But Matthias, next time I'm in Bern, you owe me a dinner for lunch, so we can have a much better conversation about this.
Thanks for your encouragement. The Swiss healthcare system is also for profit, is profit oriented. And actually, people are not interested in knowing about, duplication, overlap, bad practices, because they're earning money with it. So that's another aspect. But I'll stop here, and other people. I thought Carol wants to ask a question.
Carol, go ahead.
Yes. So Jeremy, you spoke a little bit about the different frameworks that are used, and kind of that there were no framework, and now we have like plenty of them. And so I became aware of that also in my master, in my course on implementation science. And I have the feeling sometimes that researchers are not doing implementation research, but implementation researchers are just so much focusing on developing a new framework and validating a new framework instead of giving kind of guidance on what to use and how to apply them. So you touched a little bit about the TDF, but it doesn't apply to everything. Do you know of any guidance to help researchers do implementation research when they are not implementation scientists?
So the first thing I'd say is try and find people you trust to work with who've got implementation science background. I mean, my sense is that what we should be trying to do is test these theoretical frameworks to death rather than developing new frameworks. Because and it's one of the reasons why we've used TDF now for about 20 different studies. And we did that very much on the basis that if we changed the framework every individual study we did, we wouldn't cumulatively learn. So we have a good sense about his strengths and his weaknesses. There are groups that are doing something similar with CIFA, and there are groups that are trying to bring CIFA and TDF together. And I think that's what we need. And there's groups doing, I talked about the normalization process theory, Carl May's theory. So my sense is I would be largely trying to pick up on existing frameworks, trying to operationalize them as well as you can, be very critical about what they do and what they don't tell you, and then and test them in the most robust way, rather than going, developing your own framework, being more and more esoteric. The issue is that all models are wrong, all frameworks are wrong, some are useful. And I think what we need to do is identify what the useful ones are. TDF I find useful because it really says, don't think of it just knowledge, it's actually much broader. CIFA, unpacks broader the sort of the outer context, I think, better. TDF, the normalization process theory does very much thinks about the kind of the diagnostic process and the understanding about workflows. So I would, use a limited number of frameworks. I use frameworks that you think have some empirical validation. Some empirical validation that are testable. There's an awful lot of theories that are, good ideas, but they've not been any way operationalized in a way that you can actually, use them in a reliable way. But it is difficult. But this is why, again, I think building capacity, working with other disciplines will be really helpful to try and advance this.
Okay, thanks very much, Jeremy. I see there are 2 persons who have questions. So Moria, you have also one question, is it correct? To put in the chat.
Yeah, hi, Jeremy. As always, great. Just a quick question. You mentioned the importance of collaboration, which we know is super important, and the implementation research labs. So there are a few labs, more centers than labs. And I know that in Europe, they're trying to connect these centers through the European Implementation Collaborative. But is there any effort internationally to connect these labs so they're not duplicating each other's work, et cetera? And, I'm aware of BESI, et cetera, but is there really an initiative? Because we don't want to just keep everyone doing their same thing or reinventing the wheel, as you had alluded to throughout the call. Yeah,
one of the issues is I think I've given you my flavor of implementation research. There are other flavors of implementation research. There are people who particularly focus on an organizational perspective. There are people who talk about it in a very transactional way. And so one of the issues is that I think that people come at this from slightly different perspectives, and sometimes that becomes a barrier to people getting in the same room because it takes time to then build those relationships. So I'm not aware of international. I think people are aware of who's out there and what they're doing, but I don't think there's that many, sort of formal international collaborations. Where we have had success is when we've focused around a particular problem or a particular intervention. So I lead something called the Audit and Feedback Meta Lab, and that was very much basically wanting to build implementation research laboratories, links between audit and feedback research and healthcare systems to do A/B testing of audit and feedback interventions in jurisdictions. And from the get-go, we have had the International Audit and Feedback Meta Lab, where we currently have about 50 scientists around the world, all focusing on audit and feedback. And we have, I think, about 6 or 7 groups that are doing large-scale research at that level of working with healthcare system partners. But I think that was easier because it was around a particular sort of intervention. We're doing something similar with antibiotic prescribing in primary care. So I think what we probably will get is more clusters where there's a shared issue, because the implementation landscape is so huge that you often find people talking at cross purposes, where if you can break it down, and then we do need to have people who will be bridging. And I think a key issue will be for the senior people in the field to try and act as those bridges between these different networks, and the junior people in these field who might have their feet in 2 or 3 camps to sort of try and work it together.
Okay, thanks, Jeremy. I think we have another question from Saloni. Is it correct?
Yes, thank you so much. Thank you, Jeremy, for your very informational and relevant presentation. I'm a junior faculty at Tufts University in Boston, United States, and I do mental health implementation science research. And I've established collaborations, I've been seeking more collaborations, but I feel like one roadblock is to get buy-in from universities and organizations for implementation science research, especially for like internal funding or smaller projects. What tips would you have for building that foundation for implementation science research as a junior faculty?
Knock on lots of doors and kiss lots of frogs. And one of the frogs will turn into or hopefully more than one frog will turn into princes who want to do work in this area, or princesses, or whatever animal we want to use. I think there's, when I started, people didn't actually use the term implementation science. And so, you need to find what are the arguments to get people. And a lot of people recognize that care isn't as good as it could be, that our patients are suffering, despite, the people wanting to do the best that they can, they're suffering. And some of that is because of, a very outdated view about what, we publish and somehow go into guidelines and the world will be a better place. So I think you need to develop scripts where you can sort of start to sort of work out, what are the arguments about, well, we know that sort of, 30% of patients who are on antidepressants are on too low a dose or have too short a course for benefit. Or we know that actually, non-drug treatments have these components would be effective. But what would you have to do to make that work through? What are the uncertainties? And try and make it very concrete. One of my worries about implementation science is I think at the academic level, it's getting quite abstract. And I think people in healthcare systems are really, really concrete. So make it something that they kind of get and understand. And then I think it would be, you only need to find 1 or 2 or 3 people. And they don't necessarily have to be where you are. The biggest thing that happened to me was, or in my early career, was I was able to connect with Martin Eccles. And he was based 240 miles away from me. And once a month I'd go down and see him, and once a month he'd come up and see me, and we developed what was a very, very substantive at that time implementation research program. It doesn't need a lot of people, but so I would keep knocking on doors, think about what's going to appeal to this person, what is going to be the thing, and be versatile. We want to try and improve patient medication compliance. Well, that might give you 2 or 3 different ways in of how to do things. And I think in the mental health space, I think there's, particularly in the US, I think there's a number of groups doing outstanding work. So if you're not connected to CERC yet, you should connect to CERC, because they very much come from that mental health perspective. There's the implementation journal that they have, can't remember what it's called now, but it's not easy. But I think you have to believe. I've always had this foolish idea that what I was doing was the right thing to do. So you have to have that belief, and then basically bring people into that and just slowly build things up.
Okay.
Thank you.
Thanks very much. I think we should be about at the end of the round of questions, except if there is someone who has a last urgent question. Okay, if not, thanks very much, Jeremy. And as we discussed before also with Matthias, I think it would be great to have you in person in Bern, hopefully in some months, perhaps next summer. Perhaps it would be a bit better with the pandemic, or next fall, we will see. We need to be a bit careful about dates, as we know from the last months and 2 years. So, but thanks very much for the great and inspiring talk, and hope we will be able to continue some project together, and also invite you to discuss about further project, and certainly also the next talk with an apéro and dinner to discuss about the complexity in Switzerland and the issue, how to make the implementation research more prominent also in Switzerland. So thanks very much, Jeremy, and thanks very much for your time, and have a safe trip back to Canada. Bye. Thanks.
Thanks a lot, everyone. Bye-bye.
Thanks for all to attend.